Good morning, everyone. It's Mark Crowther. I'm chair of the Department of Medicine here at McMaster University, and welcome to Medical Grand Round. Today to be presented by Dr. Mark Matsos. Just a couple of work business-related items. The first is we're using the webinar function in Zoom for today's rounds, and as a result, please enter your questions. I prefer into the question and answer panel. It's easier for me to manage that, but if you want to enter them into the chat function, that's also fine. We do have an attendance code for today's rounds. It'll be on Dr. Matsos' slide, but for those on the phone, the code is CH8249. That's CH8249. During the course of rounds today, again, please feel free to ask questions at any point. If they are timely, meaning that you need to know something right away, I'll interrupt Dr. Matsos. Otherwise, I'll just collect them all at the end and we'll ask them at the end. We will go for about an hour. I apologize, over the last couple weeks we've had more questions than we can answer, but I know people have commitments, including me having a clinic that starts downstairs in exactly an hour. So we will end at exactly 9 o'clock. So without further ado, I'll ask Dr. Matsos, who's going to talk to us a little bit about a drug which has received a lot of press over the last couple of months. Dr. Matsos.
Thanks, Mark. I appreciate that, and thanks everybody for joining in. So, you know, the title of my talk, Requiem for Hydroxychloroquine, seemed apt given sort of, you know, as Mark actually described to me in our pre-presentation talk here, the roller coaster that we've all been on, and certainly that applies to, you know, the news and data, particularly around this medication and other aspects of rheumatologic care. So today we're gonna focus in on that, and I'm gonna take you through basically what for me has been a 3-month kind of arc, my experience with this, and I think a commonality shared with many of my colleagues in rheumatology. So for those of you needing the attendance code, it is here. And just before we get going, in terms of disclosures for me, I am a primary investigator in multiple phase 2-3 studies looking at novel therapeutics in lupus with the following companies. You will all be happy to know, hopefully, that I do not have any financial interests in any pharma company that are related to Plaquenil or hydroxychloroquine. So I don't perceive that there's going to be much bias here from that standpoint. The other thing I'd like to do just as we start here, before we get into the meat of the topic, I just want to personally acknowledge all of my colleagues on this call who have really been on the front lines of things, whether it's screening or in hospital care over the last you know, 3 to 4 months that we've all been living in this you know, funky dream world of ours. I will tell you that it's a kind of a weird experience as a clinician, seeing your colleagues prepping and heading into you know, frankly, what would seem like battle, or prepared to be in battle every day, and sort of being sidelined a bit as a more ambulatory outpatient physician. And I don't think I'm the only one of my peer group who in the back of our you know, heads sort of had the niggling thought that there was, you know, a wish that we could kind of, in quotes, do more. And this despite the fact that you know, most of our professional lives and personal lives, like all of yours, have been completely upended by this. And just sort of reflecting back on the experience as someone a bit arm's length from, you know, the nitty-gritty day-to-day sort of dynamics of this pandemic and its impact on the healthcare system, you know, sort of wanted to offer a bit of a reflection of what it's like from the perspective of a rheumatologist. And while I was certainly struggling to do that, one of my colleagues, Dr. Seth at Stanford, who's a rheumatologist, you know, published a reflection piece in one of our journals, the Annals of Rheumatic Disease, in late April, in an online edition, and it was entitled Hope. And I thought I'd just offer a few phrases. I did not certainly put the whole thing here, but just to sort of give everybody the perspective of you know, what it's like being a rheumatologist here, and sort of some of the emotional roller coaster that we've gone through. And the key points here, you know, that Dr. Seth sort of reflects on is, you know, the initial stress that we all had, you know, not being on the front lines of the pandemic, but there was always that yet. And certainly, you know, we were very fortunate locally that, you know, our levels and the strain on the system never amounted to what amounted to other locales like New York and in Italy, where, you know, certainly we had rheumatology peers in those communities, amongst other sort of non-kind of acute medicine physicians who were providing care for patients. But, you know, certainly for the first several weeks of this, when we weren't sure how the pandemic was going to affect us, I think many of of us had this in the back of our thoughts, and it even drove me to to review things like the management of ACS and the use of antithrombotic therapy in that context, God forbid. And so fortunately, we got through that hurdle locally at least. There's the hurdles that we've all faced, and how do we provide care for our patients? And Dr. Sethi reflects on the ability to try to examine for synovitis on a video visit. One of our primary outcomes as rheumatologists for many of our patients with inflammatory disorders, when we try to answer the question, how's my patient doing? The swollen joint count is one of our primary metrics that we look at that help us adjudicate where we are in treatment. And I will tell you now, the video examination of a patient's hands or wrists or any other part of their anatomy, frankly, as it pertains to the MSK exam, is woefully lacking compared to the ability to physically examine a patient and get that data. And so, that has been a big shift for us in terms of trying to find potentially other ways that we can accurately assess how our patient populations are doing without the benefit of a physical examination. And then we went from that to certainly what we're going to talk a bit about today as well, is the hydroxychloroquine dynamic. And you may think that rage is a strong term. I assure you, at least in my case, it was not. And there was plenty of rage on my part, starting in mid-March, primarily as someone who treats a cohort within my own clinic setting that has a lot of lupus. And I will tell you, cannot overestimate the impact that the hydroxychloroquine debate has had, certainly on the psyche of that patient population in particular, as well as those of us who treat it. But at the end of the day, I think for most of us now, 3 months into the pandemic, the last line there is something that us, and I'd imagine a lot of other physicians, and particularly those in ambulatory care, have kind of put on their wall, which is: I adapt, I persevere, and I trudge onward. And so with that, we will trudge onward through this rounds. So our objectives today, the first one is we're going to talk a little bit about the impact that this virus has had on patients living with systemic rheumatologic illness. I'm going to talk a little bit about some of the emerging immune-mediated clinical presentations that we've seen with COVID. And we're going to, of course, talk about, to me, what was somewhat surprisingly the utility of some of our rheumatologic therapies in the management of patients with this virus. So, I think as rheumatologists, we all felt that, this was obviously, we were going to have a significant role to play given, a pandemic virus for which there's no, natural immunity in a population of patients at risk for infection due to, dysregulated immune systems from their autoimmune illness, not to mention all the various therapies that we throw at their immune systems to stop them functioning. But I will say, I don't think, at least for me, things didn't get, in quotes, real until a sequence of events unfolded in about mid-March. And a year ago, if someone had told me I was going to be presenting grand rounds, and first of all, quoting Twitter, and second of all, quoting the Twitter feed of our friendly president down to the south of us, I would have thought you would have lost your mind. But here we are. It's 2020, and I'm quoting Donald Trump in Twitter on a grand rounds for the Department of Medicine. And you can imagine, March 21st this is following a news conference on the 20th where the president first, floated quite forcefully the idea that hydroxychloroquine was basically going to cure COVID, and it was with some bewilderment, I will say, that was quickly followed by abject horror that I saw these tweets come out and shocked at the ability of the president to even say the word hydroxychloroquine, which he said perfectly, by the way, in that news conference. And this really kicked off the firestorm, I think, for a lot of us in rheumatology in terms of understanding the impact that this was potentially going to have on our patients. And really, at the outset of this, three broad questions that we had as a group as we sort of thought about our patients. And the first one, of course, okay, so what's the actual risk here to our patients in terms of, how bad is this infection going to be for our patients with autoimmune disease who are immunosuppressed? And what's the severity of these infections going to be? what is the impact that the drugs that I'm giving my patient, how's this going to influence the COVID experience in our patient populations? And I think if you ask most of us at the onset of this, we were all pretty paranoid about the potential impacts for our patients. And I spent the better part of late February into all the way into March, basically instructing a lot of my patients not to leave their homes, simply because we just didn't know. And theoretically, the concern is that this could be, fairly significant and bad for them. And then, after the data, I'll use that term in quotes, came out around hydroxychloroquine, the next question came, is it actually possible that some of the medications that we use to treat our rheumatologic diseases are actually going to be effective? And if so, what's the fallout of that, going to be good or bad for our patients living with rheumatologic illness as well? So really 3 big questions that we've had over the last 3 months that we've tried to be focused on in terms of providing some direction with really what's limited data. So if we kind of look at the first 2 questions in particular to start here, the risk of infection, severity of infection and its impact, and what role do our drugs play? Sort of one of the first kind of hints that we had was based on a cohort of patients from the epicenter in northern Italy, and that I've sort of termed the Lombardy cohort. This is sort of in the Brescia region, I believe, in Italy, where this data came in. And we had colleagues there who surveyed almost 1,000 patients living in that center between February and April 2020. And this was a population of patients heavy in inflammatory arthritis. So 96% of them had either RA or psoriatic arthritis, and a high percentage of these patients were on our biological DMARD therapies. So primarily these would likely be anti-TNF therapies, more than 80% of them. So certainly a population that at baseline rheumatologists have concerns about infection risk in the middle of a novel pandemic, even more risk. Now, what was interesting here in their survey at the time, and I mean, this is a bit of a weakness of the data here, there were only 6 confirmed COVID cases amongst those almost 1,000 rheumatology cases, and that's confirmed by PCR or other means. And now, that being said, there were over 150 in quotes suspected cases that weren't necessarily confirmed at that time. I think probably due to the limitation of access to healthcare resources and the fact that people probably just didn't want to leave their homes necessarily to actually go and get tested. And so these would have been patients who had all the typical symptom profiles of the disease. What's interesting here is that of those almost 1,000 patients that were surveyed, there were no deaths during that time, at least, and there were no ICU admissions in those patients. Again, a patient population heavy in inflammatory arthritis and on immunosuppressive treatment. Now, what was the other thing that was interesting? Less than 7% of those patients had actually stopped or reduced their therapy. Which is interesting in the sense that some of this may not have been mitigated because everybody just stopped their drug. And while certainly some of the bias here may be that people just weren't going out and therefore weren't being exposed, of those surveyed, only 45% said that they exclusively home isolated. Basically, they didn't leave their house. And so while people were still leaving, they were certainly adopting other precautions as directed by the public health measures at the time. And most of them during that period of 3 months continued to have stable disease activity. So it wasn't calamitous in terms of seeing disease flares. And so that was the first little snapshot we got of a patient cohort, in an epicenter, living with our illnesses and utilizing our therapies. Next up was a report that came out of patients out of NYU, and these are patients who had immune-mediated disease, and they had been assessed from early March through to early April. And these are, mostly patients who are receiving, again, either biologic DMARDs or other immunomodulatory therapies that we utilize in rheumatic diseases. And in this case, unlike in that first cohort I showed you, these patients had confirmed, but also highly suspected symptomatic COVID cases. Now, if you look at the little graph there, certainly the majority of these patients, despite the fact that they were on advanced therapies, were able to stay out of the hospital. And you can see though that the ones that were hospitalized, certainly oral glucocorticoids, which probably isn't a surprise, or the use of them, was significant, well, maybe not significantly, but was certainly associated at least with more hospitalizations. Whereas, some of our other biologics, and in particular the TNF, we do not see higher percentage of, in this cohort at least, patients hospitalized utilizing those. Of the 14 patients that were hospitalized, 11 were ultimately discharged home with a mean stay that was just under about 6 days. At the time that the data was published, there were 2 patients that remained hospitalized, and that was because they needed more high-level care, including ICU admission and mechanical ventilation. And 1 patient had unfortunately passed away. Now, of the patients who died or who needed more aggressive management, none of those patients was actually on a biologic treatment. So again, gave us a bit of a sense here. Again, a little snapshot, limited data. But in a cohort of patients with systemic immunologic disease on immunosuppressive therapy, at least there was not a clear, overwhelming signal that patients were going to do worse, at least in the initial phases of this pandemic. But a lot of these questions, and really what came about at that point, was the creation of the COVID-19 Global Rheumatology Alliance, and really as a means, as an international effort to help us better answer some of these questions. And so what's really neat is that what started as a Twitter discussion, within 2 weeks actually became a formal global registry with a steering committee and a patient board and oversight. And ultimately has grown to involve more than 60 countries around the world. And this is a physician-reported case registry of patients living with rheumatic disease who are diagnosed with COVID. At the time of the initial data cut that I'm going to show you some information on, there were about 850 patients enrolled from around the world, although as you'll see, predominantly from Western Europe and North America. At this point, as of the last time I checked, which was earlier this week, there are now over 3,000 cases documented, and we do have some sites here in Canada. So, and what I would like to just take a minute to do is acknowledge our Canadian facilitators of this, and locally, that's particularly Dr. Maggie Larche, who's our lead here at McMaster, and you'll see Emily Sirotek down there from MAC as well, who's taken a leadership role in the steering committee and with patient engagement as well. And I just want to acknowledge the Alliance, and that several of the slides I'm going to be showing you coming up here are based on data from that registry, and the slide deck, it was certainly helped to be created by members of that committee as well. So thank you to them. So what did these patients look like in terms of who are the types of patients in these cohorts? And you see a wide variety of rheumatologic diagnoses here, but as one would probably expect in a rheumatology practice, the predominant number of patients, percentage of patients, are patients with rheumatoid arthritis, which of course is one of the most common, at least, rheumatologic inflammatory arthritides that we deal with. You see lupus there is represented at about 18% of this patient population as well, which for me, it probably represents a bit of an overweight in this. I don't know that lupus comprises almost 20% of most rheumatologic practices, but probably reflects the fact that these patients are potentially being drawn primarily from tertiary care centers where there's more likely to be subspecialty clinics, and probably a bit of bias in the sense that we get worried a lot about lupus patients and infection. We do with all rheumatologic illnesses, but particularly lupus, and so there may have been more particular attention paid in terms of enrolling these patients within the registry. Again, because we're coming likely from a predominantly Western European, at the time at least, and North American construct, you'll see that the majority of patients are Caucasian, although we do have somewhat of a mix across ethnicity to draw on. And, similar to what we saw in non-rheumatologic patients and theoretical risk factors for worse COVID, significant number of our patients had, the associated comorbidities, whether it be hypertension, lung disease, or cardiovascular disease and diabetes, that certainly as a medical community, I think collectively we were concerned in terms of the impact of this on, risks associated with COVID and bad outcomes as well. What were these patients taking? Well, at the time of enrollment in the database, a very high percentage of patients were on conventional synthetic DMARDs. And so these are drugs like methotrexate, azathioprine, mycophenolate, things that are commonly used as initial line management, particularly inflammatory arthritis and connective tissue diseases. We had about a third of patients that were on biologic DMARD therapies, and these could be drugs that were anti-TNFs, blocking anti-IL-6, anti-IL-17 therapy. About a third of patients were on glucocorticoids. About a quarter of patients, interestingly, were on anti-malarial therapy and still presenting with infection. And a significant percentage were still on NSAIDs as well. You may remember at the very beginning of this, there was some concern that NSAIDs might actually make COVID-19 in quotes worse before I think that was partially debunked. But at the time that this data was published, that was still an active question as well. And at the time that they were enrolled in the registry, about 65% of them, their infection had resolved. And there was still about a third of patients where they were still actively infected. And so the outcomes of those cases was not yet known. And there were about 8% of patients where we didn't know what ultimately happened to them in terms of a resolution of their infection or not. So about a third where the outcome for those patients was still unclear in terms of how they were going to do. So that's sort of the data or the registry-based population in a nutshell. And realizing that there are some inherent challenges with registry-based data. Of course, this was voluntary. This is not an expansive collection of all rheumatologic patients with COVID. So of course we can't really talk about things like incidence and some challenges in that. Even though we know therapies, we didn't necessarily truly know the duration that they had been on these medications prior to becoming infected, and we weren't entirely clear on some of the dosages that were being used of these therapies. Although for the most part in rheumatology, doses of both conventional synthetic DMARDs and biologic DMARDs are relatively standardized across the board depending on your diagnosis. So what did the initial data cut of this group of about 850 patients tell us? Well, certainly one of the biggest things that we wanted to look for is, what were the predictors in this group of just patients with rheumatologic disease? Remember, we're not comparing to the general population here. These are comparators of rheumatology patients versus other patients living with rheumatic disease. And certainly no big surprise that age, hypertension, the presence of lung disease and diabetes, renal insufficiency were associated with higher risk of hospitalization in the context of COVID infection. As well, looking at the therapeutics, I don't think anyone was surprised that prednisone, at least in these rheumatic disease populations, at doses above 10 milligrams, was also associated with a higher risk of an infection. That I don't think to anybody was a big shock. Interestingly, though, when we look at things that were associated with lower odds of hospitalization, again, comparing patients with rheumatic disease to other patients with rheumatic disease, those patients who are actually on a biologic or a targeted synthetic DMARD, and really these are the JAK inhibitors that we've been using in RA and more recently spondyloarthritis, and certainly IBD patients use these drugs now as well, and specifically anti-TNF therapy was actually, potentially protective here and associated with lower odds of hospitalization. And I'm not sure that we necessarily, thought that we were going to get that signal, at least from this data. And we'll talk a little bit about why that might be later on when we talk about, some of this, systemic inflammatory nature of this illness. But that was a bit of an eye opener. And certainly, none of the other therapies seem to have any impact. And importantly, if you look down at the bottom there, anti-malarial use, hydroxychloroquine or chloroquine, was neither good nor bad when it came to hospitalization. So at least based on this sort of registry-based population of patients living with rheumatic disease, it did not appear, at least for those patients, that being on hydroxychloroquine at least had any clear benefit in terms of reducing the odds of hospitalization. And maybe an initial kind of wrinkle here that maybe hydroxychloroquine, wasn't going to sort of be the best thing since sliced bread on this. Now, and really on that basis, many of us were a little bit reassured based on that perhaps this wasn't going to be as calamitous as we thought for our patients. But again, the challenge here is that these were not patients compared to non-rheumatologic patients, and so it wasn't until more recently that we actually were able to get a matched cohort study looking at how patients with rheumatic disease compared to patients without rheumatic disease. And I apologize, I didn't get a chance to kind of match my color set here with the graph. This publication came across my Twitter feed at about 9 o'clock last night, but I wanted to include it, so I just threw it in here late last night to share with you. And this is a matched cohort study from patients that were enrolled out of the Partners Healthcare System in Boston. And as some of you may know, of course, Boston is considered one of the, or especially at the time that patients were enrolled, this was data from back in March and April, a hotspot with more than 50,000 active COVID cases at that time in the community. And so at the time that this data was done, there had been 2,000 confirmed cases within this healthcare system that were identified in electronic health record system. Of those 2,000 cases, 52 of them were patients with rheumatic illness, so representing about 2.2% of that population. And in this matched cohort study that was done, looking at how these populations differed, for the most part, they were relatively similar, except in the fact that if you were a patient with rheumatic disease that was hospitalized, you were more likely to require intensive care, ICU admission, or mechanical ventilation compared to the non-rheumatic disease patients. And so that signal there has given me at least a little bit of pause. Now, there's been some speculation as to why we're seeing this in this cohort, and there's some speculation that perhaps patients with rheumatic disease in this cohort may have been had a more severe sort of phenotype and therefore more likely to be admitted to ICU at the start compared to other patients. But that hasn't really been fleshed out. Certainly, it does not appear though that background immunosuppressive therapy made a significant difference in terms of that risk. So there may be a bit of a signal here that perhaps we're not quite out of the woods when it comes to our rheumatologic patients and their experience living with this illness. The other thing, of course, then was, well, do we have any data that tells us about hydroxychloroquine in these patients? And I'll tell you, when the hydroxychloroquine hullabaloo first started, for my lupus patients, first they went from, sort of fear that they weren't going to be able to get their drug. And I'm going to talk a bit about that later. And then it quickly went to, oh, look, I'm already on this drug, and maybe for once in my life, my chronic illness and the fact that I have to take this drug that Dr. Matzos prescribes me every day is actually going to save my life because I'm already on hydroxychloroquine as long as I get it. And so I spent the better part of almost a month in daily conversations with my patients, trying to remind them that yes, you're on hydroxychloroquine, but no, that is not going to protect you, from this infection, and no, you're not allowed to sort of just go about your daily business because you think you're on a treatment for this. I had that conversation so many times that I think my 9-year-old daughter and my wife could have probably subbed in for me on most of my telephone visits and given patients that advice, because they had to listen to me give this talk day after day at home. And so certainly one of the things I was most interested in when this initial data was pulled out of the Global Health Registry was what did baseline hydroxychloroquine use, particularly in lupus populations, have to do with anything? And this data formulated a lot of the basis for the conversations I had with patients in that, based at least on our registry data, it didn't matter whether you were on an anti-malarial or not. Your risk of hospitalization was the same. Your risk of requiring supplemental oxygen was the same, and your risk of needing more advanced measures if you were hospitalized to treat your COVID infection didn't seem to matter. And so again, another signal, at least from our registry-based data, that hydroxychloroquine, at least as we've prescribed it in rheumatologic illnesses, was not necessarily going to be a game changer in terms of risk reduction for patients with rheumatic disease. Now, there's a lot of speculation around this, and certainly some of that may have to do with the doses of Plaquenil that we generally give our patients to treat their rheumatologic illness. We usually max out at about 6.5 milligrams per kilogram per day of hydroxychloroquine. And when you look at the data in terms of what kind of is that enough to get your serum blood concentrations of hydroxychloroquine high enough that it theoretically has the antiviral effects that we're looking for from hydroxychloroquine that may be shown to inhibit COVID? The answer is we probably weren't dosing to an appropriate level where it was actually going to be effective from that standpoint. Whereas in other kind of early studies, much higher doses, double doses, loading doses of hydroxychloroquine were being given in order to try to accomplish this. So at least for our patients living with rheumatologic illness on hydroxychloroquine, it appeared that our standard dosing regimens based on some limited registry data did not show obvious signs of any protection from that standpoint. So, some of our initial conclusions, if you can even call them that, or maybe signals might actually be a better term from the global data, or some of the takeaways that we've had over the last 3 months. One is that the risk of infection in our rheumatologic populations may not be that significantly different than the general population. I think obviously the true incidence is really not known. We really don't know what that denominator is for all the reasons that have been outlined. There may be a possible signal for increased severity of respiratory disease in those of our patients who are hospitalized because of this, although that's based really just on one cohort of patients in Boston at this point. It does not look like that immunomodulation therapy significantly increased the risk of infection or severity. Again, when we compare patients, and prednisone, of course, is the exception here. Hydroxychloroquine did not obviously confer benefit with regards to infection risk, at least in our populations, with the manner that we prescribed it to treat rheumatologic illness. And that anti-TNF, that biologic signal where actually the use of these biologic therapies is associated with actually a decreased chance of hospitalization, further raises the questions, is it actually possible that some of these immunomodulating treatments might actually have a role to play in improving patient outcomes more broadly speaking? Now, why might that be? And I think, it's probably not a huge surprise when you think about, especially the more severe aspects of this illness and what we're seeing. And certainly, if you look at some of the most severe disease outcomes that are associated with the ARDS that we've seen, systemic inflammation is certainly a part of this. And I've included a kind of little pictorial there from a Nature Review publication on this that was published online last week. Just reminding us of what's happening in the alveoli of these patients, both in terms of the profound inflammatory response with the migration of neutrophils and bone-derived macrophages into the alveoli, and the pro-inflammatory sort of milieu that exists with a lot of upregulation and production of inflammatory cytokines that as rheumatologists we're very accustomed to dealing with: TNF, IL-1, IL-17, IL-6. And in fact, when you look at patients, again, with this most severe COVID phenotype, not only are we, can we kind of theorize that we're seeing these high cytokine levels in the lungs, we're also seeing higher levels in the serum as well. So maybe actually not a stretch that, again, in those systemic inflammatory response syndrome patients, maybe trying to modulate the cytokines that are driving a lot of that and try to rein back in the immune system might actually lead to better outcomes. Similarly, from a rheumatologic standpoint, I don't think it's a surprise to any of us that we were going to see potentially MSK or rheumatologic like clinical presentations, because if you look at any infection, whether it's influenza or any other, we see MSK manifestations of infection. There's also evidence of endothelial inflammation as part of this disease with the prothrombotic states that were talked about, and this probably drives a lot of the cutaneous features that we're used to seeing in rheumatology, like vasculitis. And then the other question is, outside of the acute sort of reactions, what's the chance there's going to be more of a long-term kind of rheumatologic implication in this through the idea of molecular mimicry and a potentially environmental trigger in genetically susceptible populations for autoimmune disease? And in terms of trying to answer patients' questions, why did my connective tissue disease or why did my inflammatory arthritis start? We always struggle with explaining to people that the mix of genetic susceptibility and then the environmental factor that has to come into play to influence those genetic factors to launch a chronic non-remitting autoimmune illness. And viruses of some sort have long been on the list of environmental factors that we feel are likely triggers through the idea of molecular mimicry in terms of launching autoimmune illness. Epstein-Barr virus in the context of lupus would be an example of this. And I think, one of the things we have to start contemplating is, what role is this novel coronavirus going to play in these susceptible populations? And are we going to see an increased incidence of immune disease, at least from a rheumatologic sense, down the line? So at least when you think about kind of viruses across the board and the type of MSK manifestations we see, it can be anything from arthralgias or myalgias to a self-limited arthritis process to a chronic non-remitting prolonged inflammatory arthritis that we see induced by viruses. And it looks like to date the coronaviruses, and that includes COVID-2, the original SARS virus, as well as MERS in terms of what's been reported. It looks like we're not seeing actual true frank synovitis in the joints or prolonged kind of non-remitting inflammatory arthropathy in these patients. It's sort of more of the lower spectrum of stuff, joint pain, muscle pain, but without clear clinical evidence of inflammation. And at least to date in available data, we see about 15% of patients who are reporting frank arthralgias and a higher percentage of patients who are reporting myalgias. And again, for the most part, these symptoms are rather indistinguishable from any other significant upper respiratory viral infection, and influenza kind of being the prototype for that. It's a lot of those kind of manifestations that we're seeing. And this is a little bit different compared to things that we see with things like parvo, B19, and rubella and hep B, where you can get a very limited frank synovitis occurring in patients from, that can last anywhere from sort of 6 to 8 weeks before it peters out as a self-limited process. Why parvo, as an example, can actually look like rheumatoid arthritis when it first presents. And a more chronic prolonged arthritis, which is what we can see in patients with hepatitis C, and also some of the alpha viruses. And the classic example of this would be chikungunya, in terms of, viral infections that can trigger a chronic non-remitting arthropathy that in some cases actually needs prolonged immunologic management to deal with. The other interesting wrinkle here when we talk about arthritis per se and future risk is that there is some data, and this is mostly out of Korea, that's suggested that some of our endemic human coronaviruses, so not necessarily SARS, but this would be more example of parainfluenza and metapneumovirus, are actually associated with future increased risk of rheumatoid arthritis. And so there may be a bit of a signal there that, well, maybe not in the acute phase of all of this, but down the line, we are going to see a potentially significant impact of these viral infections on future emergence of rheumatologic illness in some patients. So that'll be something I think we're all collectively paying attention to down the line here. So outside of the joints and muscles, of course, lots of skin stuff. And I think this is, you probably, if you've been following this, it's not news to you that we're seeing all sorts of different cutaneous manifestations of COVID-19 as part of sort of this inflammatory process. And certainly we're seeing clinical presentations of things in the skin that we're accustomed to seeing in rheumatology. This is one proposed sort of classification system for the types of things that we're seeing, and we're seeing anything from urticarial type rashes in box A to more confluent changes in the skin in B there, and D, more papulovesicular eruptions as well. And these would sort of be, your more, I don't know if typical or expected potential cutaneous kind of manifestations of a nasty viral infection. But if you look at CE and F, we're now seeing examples of cutaneous manifestations that are associated with a more pro-inflammatory state. C is, of course, chilblain-like lesions, cold-induced vasculopathy, basically lesions without, in these patient populations, at least the clear cold-induced aspect of it. And so these would be your COVID toes that you've probably heard about. We are seeing some patients with vasculitic changes and purpuric lesions as well as part of the response. And we're even seeing livid epidermoreticularis and racemosa, that kind of lace-like erythematous pattern on the legs, being part of patients' clinical presentations, and probably speaking again to the underlying inflammation in the endothelial system that we're accustomed to seeing in patients with systemic vasculitides and connective tissue diseases as well. COVID toes, I want to just briefly talk about. So the pictures I'm showing here are actually one of my own patients who sent me these photos saying, "What the heck is happening to my feet?" And interestingly, this is one of my RA patients on anti-TNF therapy who did have about 2 weeks of classical sort of upper respiratory tract infection symptoms, low-grade fevers, mildly productive cough, some sinus congestion. Was not tested. I lied. Was tested for COVID, but certainly well after the infection seemed to have resolved and was negative, and had these develop about 2 weeks into her clinical course near actually the end of when her respiratory symptoms were settling down. And these perennial lesions in her occurred without a typical trigger. On average, they're occurring about 9 days after the onset of symptoms, and they can last on average about 14 days. And so my patients certainly fit into that. When these have been biopsied, they are showing certainly a lymphoid or a lymphoplasmacytic infiltration of the dermis, and there is endothelial activation there, no big surprise. And generally speaking, we're tending to see these as a later manifestation in the course of the illness, usually in younger patients, oftentimes with less severe disease, and on that basis, oftentimes with negative COVID testing. So an interesting association here. And I think many of the rheumatologists locally and certainly in our groups have had probably their own kind of firsthand experience with this as well. One of the other kind of emerging kind of inflammatory symptoms that I obviously raised a lot of concern, and this now is kind of just leaving the skin or the joints and moving into more systemic inflammation, is this Kawasaki-like syndrome that we're seeing, that was reported in pediatric populations initially in Italy and then in New York City. That's been termed PIMS for pediatric multisystem inflammatory syndrome, temporally associated with COVID-19. Locally, it's also just known as MIS-C. As well. And these are, kids presenting with fevers, clear signs of inflammation, high white blood cell counts, high CRPs, some lymphopenia, and evidence of either single or multi-organ dysfunction. And initially, when this presented, it was felt that, do these kids actually have atypical Kawasaki's disease? Because some of them would meet partial, in some cases actually full criteria for Kawasaki disease, and especially after having other microbial causes excluded. And again, there's a variability here in terms of whether, the SARS PCR testing is actually positive or negative in these cases. Now, for those of you who just need a brief primer, a reminder what Kawasaki is. Kawasaki's disease is a rare acute pediatric vasculitis, and its primary complication is coronary artery aneurysmal changes. And the typical presentation is in children usually less than the age of 5, with the clinical features you see here in the pictorial. And the original reason this came up was that, again, in that northern Italy sort of epicenter of COVID, during the peak time between March and May, all of a sudden there was a higher incidence of Kawasaki disease and Kawasaki disease-like presentations being reported. That was 30 times higher than the incidence at any previous time in the last 5 years. So there's a kind of this surge of these sorts of things, but it wasn't typical. And what was being found is that the patients who were felt to have the systemic inflammation syndrome associated with COVID infection were an older population of child. So these were kids that were frequently older than the age of 5. While many of the classic Kawasaki disease features were present, they weren't all there. And in particular, you're seeing more lung and GI manifestations, and we're more likely to have signs of cardiac involvement. Biochemically, seeing much higher ferritin levels and reflecting probably a more strongly systemic inflammatory state. And compared to the usual thing in Kawasaki, seeing more lymphopenia and thrombocytopenia as well. And the other thing is these kids were more likely to have a severe disease course and in terms of having more resistance to the typical therapies and needing higher doses of steroids. and more likely to have bad outcomes in terms of myocarditis, shock, and higher rates of clear cytokine storm or things like macrophage activation syndrome as part of this. And I just want to thank my colleague, Dr. Michelle Battiche, who's the head of pediatric rheumatology here in Hamilton, for sharing some of her insights with me in this particular slide, and just in our own conversations. Michelle, yesterday said we have yet to see a case of this, at least locally in Hamilton, although the Canadian, pediatric rheumatology community remains vigilant in terms of looking for this, but we haven't had a case locally. And then finally, we're seeing the cytokine storm, and this is kind of like the pediatric version or the adult version of this pediatric PIMS thing, and this is basically where we're seeing, because of high levels of pro-inflammatory cytokines like IL-1, IL-6, stimulated by this virus. We're seeing patients that almost look like they have some of our classical, what we consider our hyperferritinemia syndromes, like adult onset Still's disease or secondary HLH. And really, this is where the question has been asked: is there a chance that we can glean something from the treatment of those particular systemic inflammatory states and apply it to the critically ill COVID patients that may improve outcomes, particularly therapies that target IL-6 and IL-1, because this is how we go about treating these cytokine storm syndromes. And when you compare severe COVID versus other kind of syndromes that are kind of fall into this category of the hyperferritinemia states, whether it's sepsis, adult onset Still's disease, macrophage activation syndrome, or catastrophic antiphospholipid antibody syndrome, there's not a ton that actually differentiates these syndromes, except perhaps the degree of ferritin elevation in the MAS cases that we see. So there is definitely a similarity in terms of how profoundly inflammatory they are, as well as the coagulopathy states and the thrombotic risk that goes along with these patients. And so really this has spurred further investigation, even outside of hydroxychloroquine, into some of our therapies. And I borrowed this slide from one of my colleagues in Europe, Felton and colleagues, who published this, who at least as of late April had found at that time at least 143 individual trials looking at, 363 studies looking at various aspects of rheumatologic treatments. And of course, hydroxychloroquine was primary, but you also see drugs like tocilizumab and sarilumab, which are IL-6 blockers, and anakinra, which are IL-1 blockers, as part of this now as well. So we do have some very preliminary data on some of these therapies, and it's not enough certainly that we're going to draw conclusions from them, but again, it's an interesting signal. The first is in this study that looked at the role of anakinra, again, one of our anti-IL-1 therapies, and its impact on patients hospitalized with severe COVID. And this is data out of a hospital in France. And basically they created a prospective cohort of patients aged 18 years or older with severe COVID based on bilateral pneumonia or on their chest x-ray or CT scans. And they compared them to a historical cohort of patients who had been admitted previously that were on standard of care. And standard of care at that time, at least, was hydroxychloroquine, azithro, and IV ceftriaxone. And what you can see here is that in the group that was treated with anakinra, compared to the historical group, interestingly, it certainly seemed to be protective from the standpoint of mortality, and as well as significant in terms of less mechanical ventilation being required as well. So maybe a signal here in again these most severe cohorts that possibly blocking some of these cytokines associated with systemic inflammatory states, could be of benefit in that severe cohort long term. Similarly, when we look at one of the other very pro-inflammatory cytokines, IL-6, and we're used to blocking this in RA with these two drugs, sarilumab and tocilizumab, well, again, we can't say anything conclusive based on early data. There's some suggestion based on the analysis of a retrospective study out of China in the case of tocilizumab, where 21 patients diagnosed as having severe or critical COVID had good outcome. Again, there wasn't really a comparator group here though, but all patients on this treatment were discharged, and within 5 days of getting the treatment, there were clear biochemical signs of improved inflammation in terms of improved lymphocyte levels and decreasing of CRP levels. And again, also in sarilumab, which is another IL-6 blocking agent, that again, a more critical patient populations that there may be of benefit here. So both of these data and other kind of case series data have stimulated, formal RCTs that are being done that will hopefully answer the question with better data and a more clear signal in terms of their true utility of these particular therapies. And then finally, we are also looking at the role of another class of drugs called JAK inhibitors, and baricitinib is the classic one here in patients potentially with less aggressive disease. And the reason we're doing this is baricitinib is suggested to have antiviral effects by blocking the AAK1. And this is an important mediator for endocytosis of SARS virus into cells. Again, there's a signal here that there may be benefit, but again, a formal RCT being done by the NIH is in progress. Okay, so with the last bit of time left, I do of course, want to talk a little bit about hydroxychloroquine. And when everything, went nuts in March, certainly the first thing I did as someone who prescribes this drug every day and half for the better part of a decade, went back to say, where is this coming from? Why is this drug being targeted, in terms of this particular virus? And certainly there was old data at that time and preclinical data that antimalarials in vitro actually had antiviral effects versus COVID. And if you look at the reference, it actually dates back to 2003, which is the last time we had a SARS infection. And the theoretical model here is that hydroxychloroquine, because of the way that it alters pH within cells, was also able to inhibit the pH-dependent steps of viral replication and been shown in vitro to have effects against retroviruses. And in fact, it's actually been looked at in HIV, which I didn't know, flaviviruses, and of course the coronaviruses. And the thought here is that through these mechanisms, the drug has the ability to impact the endosome-mediated viral entry into cells in some of the late stages of replication. And in particular, it's been shown that hydroxychloroquine can actually inhibit the terminal glycosylation of that H2 receptor that we've all heard so much about, and thereby potentially prevent viral entry into cells because it restricts the interaction of this receptor with the SARS CoV-2 S protein. So the theoretical basis here for why this drug might work in COVID. And I'm a bit of a history buff, so I went back and had a look at some of this data from 2003, and in the summary from the authors of this Lancet Infectious Disease paper, they were actually almost a bit prophetic in this, and I've left it here somewhat unaltered just for you to review. But their final closing thought of their original article is that we should remember that the possibility of new outbreaks of SARS cannot be excluded, and in the absence of effective inhibitors of SARS coronavirus, the possibility of inhibition by hydroxychloroquine in antimalarials, at least in vitro, would represent a breakthrough. And they recommended that people go through and study this. We emphasized the need for testing in cell cultures infected with this. And in 2006, they actually published a paper that had shown just this, that hydroxychloroquine actually had potent anti-SARS coronavirus effects in vitro, again attributed to the glycosylation inhibition of this receptor. If anyone's interested, that's the reference there of the paper where they actually demonstrated this. So fast forward to the future. And in early March, we get the paper out of France, Gautret and colleagues that demonstrated that hydroxychloroquine plus azithromycin enhanced viral clearance. I don't have enough time and not in the scope of this presentation to go through that data, but I think fair to say it's been picked to death in terms of some of the weaknesses of the associations and conclusions that were drawn from that. However, despite that fact, these results were clearly amplified on social media. We had the president tweeting about it in Canada. This was one of my favorite tweets. New controlled clinical study conducted by doctors in France shows that hydroxychloroquine cures 100% of coronavirus patients within 6 days. It's a miracle. Of course, this was then endorsed by governmental and institutional leaders. And then we started extrapolating these findings even more based on flawed data to suggest that maybe hydroxychloroquine could actually prevent infection or be used as post-exposure prophylaxis. And of course, the president famously claimed that he was on it. And so this data, I found this kind of neat. So this was published by my colleague in the Annals of Internal Medicine. It shows you what happened in around that time with hydroxychloroquine. So March 17th is the publication of the article. March 20th is the presidential press conference. What you see on your y-axis there is the internet search interest in the terms hydroxychloroquine and chloroquine. And you can obviously see huge spikes around those two events, which are then mirrored by actual drug shortages of hydroxychloroquine. And this is how I spent my first two weeks of of March was dealing with the fallout of the hydroxychloroquine shortage, which we did feel in Canada, as well as in most places in North America. And in fact, the Lupus Foundation of America just a couple days ago published the results of a survey of 3,000 US lupus patients, who 55% of whom had difficulty accessing Plaquenil between the months of March and May 2020. And why is that? Why is that such a big deal? Well, I've posted here the media release that Lupus Canada, which is the largest patient advocacy group in Canada for patients living with lupus, submitted in conjunction with a number of us as physicians who treat lupus, just highlighting the fact that hydroxychloroquine is not just a speculative treatment in lupus. And if you follow the red arrow, it says, for those living with lupus, hydroxychloroquine is proven to reduce mortality by 50%. It prevents disease flares, reduces the need for hospitalization in our patients. So being without it is a very profound problem in lupus populations. And we were really concerned about the risk of flare and bad outcomes. On top of that, we provoked a whole new set of anxieties, because as hydroxychloroquine got prescribed to everybody started to come out of the woodwork saying, well, hang on, is this really safe? And all of a sudden we had people saying, well, we're going to cause all sorts of other problems by giving hydroxychloroquine to patients, which historically as rheumatologists, we tell our patients is really safe. And in particular, it was the cardiotoxicity and risk of arrhythmia. And it seemed that everybody who was getting hydroxychloroquine was also going to get torsades because of the theoretical risk of QT prolongation. And the third wave of coronavirus for me really is when my patients, who at one point were first fearful that they could not get their Plaquenil, were then happy because they thought their Plaquenil was going to save them from corona, were there exceptionally upset at me because I had been giving them a treatment that was going to lead to their certain cardiac death, even though I was protecting them from their lupus. And that is still an aspect of this that I'm personally am dealing with as I try to counsel patients around some of the knowledge translation that has gone on in social media around these things. But it got to a point where I actually started to question myself about the safety of what I was doing from a cardiac standpoint. And in case you're still wondering about this, I actually went back and looked to see, maybe I've been undercalling this all these years, and maybe if we started using hydroxychloroquine at high levels in the population, we were all of a sudden going to see this surge of arrhythmia and sudden cardiac death. And I thought, well, there's at least one population of patients that have been using this drug for a long time, in very large numbers, and that's to treat anti-malaria. And so I went back, looked at a World Health Organization publication called The Cardiotoxicity of Anti-Malarials from 2016. And reassuringly, what I read was, despite hundreds of millions of doses given for the treatment of malaria, there have been no sudden unexplained deaths associated with these drugs, and particularly chloroquine, although these drugs can cause QTc prolongation. And that was further followed by a publication from the American College of Cardiology, reminding us that the relationship between QT prolongation and the risk of torsades is complex, and that is not a linear function. And that, again, echoing the World Health Organization, that several 100 million courses of chloroquine and hydroxychloroquine have been used worldwide without reports of arrhythmic death under WHO surveillance. So fortunately, I still think from a cardiac standpoint, at least from a safety signal, we're okay in our patient population. And so just in closing, certainly it's been a whirlwind, I think, for all of us. And for those of us in rheumatology, with all this concern around our patients and the fluctuating data on hydroxychloroquine, I can tell you that Dr. Fauci's posture in this slide clearly mimics my own for most of the better part of 3 months. I think outside of the scope of this talk to make any definitive conclusions on hydroxychloroquine and its role, and mostly because, frankly, and I'll leave it to my colleagues here, Dr. Al-Hazani and the ClinEpi group, basically our methodology is poor. We don't know. And further, certainly in one of the decent RCTs, the recovery trial, which was also the trial that recently suggested the benefit of dexamethasone, in their hydroxychloroquine arm, it was shown not to show any significant difference in their primary endpoint of 28-day mortality. And so mercifully, much like this talk, hopefully the hydroxychloroquine story has come to an end. And on June the 15th, the FDA published this on Twitter, revoking the emergency use of hydroxychloroquine. Coincidentally, June 15th also happens to be my birthday. And you can see the smile on my face there as I'm going to blow out my birthday candles. And I will tell you that smile is because I had read that tweet about an hour earlier. And I was thinking to myself, dear God, please let this hydroxychloroquine story be over. although it would have been wonderful if this drug could have been proven to be of benefit in patients with lupus. I think with all the misinformation and all the chaos that ensued from it, I personally, on a very selfish level, will be a bit happier if this has finally been put to bed. And so with that, conclusions, frankly, I don't think there are conclusions here. I think in these early days, there's still questions rather than answers. From the global registry, maybe this virus isn't going to be quite as bad as we initially worried in our rheumatologic populations, we hope. Immune modulating treatments, they don't appear to be harmful. Could they still be helpful? I think the jury's still out, but lots of data still to come. We still don't know what the long-term implications of this infection is going to be for the immune system. And are we obviously going to see a tidal wave of immunologic diseases down the line? And as it pertains to hydroxychloroquine, has this been a missed opportunity? Was it always just snake oil? I'm going to let you draw your own conclusions to that, because I'm frankly still not sure that I know as well. And with that, I thank you for your attention, and I'll open it back up to questions. Thanks.
Thanks, Mark. That was really excellent and very comprehensive. Great review. It's neat how people can put together great rounds on fast-moving topics, and this is certainly one of them. We're actually just at time, so I'll just ask one of the questions that came into the question and answer thing. So if there's a hint of a signal that anti-inflammatory medications may reduce the severity of SARS-CoV, and that's come up in the hematologic world too, where you said tocilizumab has been used in this disease. Certainly some hints there that may be effective. Has that ever been found in other severe respiratory diseases, particularly those associated with an ARDS thing, like very severe influenza? Have people looked at those issues?
Yeah, I think a great question. I don't know the literature well enough in those areas. My initial response is I don't think so. I haven't seen it if it has, but I also haven't done a exhaustive lit search looking for that evidence. I don't know if any of my critical care colleagues who may or may not be on this call could weigh in on that, because they would probably be more familiar with it. But as far as I know, there has never been a lot of impetus necessarily to look at it in high detail outside of the COVID situation. Although of course, steroids being of benefit and possible benefit in ARDS may suggest that these drugs could have a role in patients that are clearly showing kind of more systemic inflammation in the context of, say, an ARDS type picture.
Cool. Okay, thanks. Well, we should end there because it is 9:01. I'd like to thank Mark for a really great set of rounds and highly illustrative of both COVID, but also of the advances that have been made in only what seems like years, but it's actually only a couple of months. For those attending rounds, this will be the last set of rounds formally until September. And in September, we're going to resume the usual rounds where the physicians in chief at the 2 hospital sites will lead most of the rounds, and chairs rounds will drop back to once or twice a month. We're just working on the schedule now. So I'd like to thank everybody who's attended religiously over the last couple of months as we've done these. We aren't sure whether we'll resume face-to-face or on Zoom or in some kind of hybrid fashion. I suspect hybrid. If you want to fill out the evaluations, we do share them with the speaker, and Gail will be sending those to you. And again, just for those of you who are on the phone, let me just quickly look up the code here. The code is CH8249. So if you send that along to Gail, she can track your attendance. Thanks to Dr. Matos for a great set of rounds, and thanks for everybody for attending both this set of rounds and the last sets of rounds over the last few weeks, where we've cobbled together a schedule in the setting of SARS-CoV-9 or on COVID-19, which has caused us a lot of excitement. Thanks, everyone. Talk to you later. Bye. Thanks, Mark.
Thanks, Mark.